And yes, it was in the 1990s that we really got imaging into the ER. Till that time, I think a lot of us were using clinical skills, ECG, and it was working well. But I think these three modalities, as you can see, the nuclear technique, CT, and the echo, which includes even dopamine stress, really came in the 1990s. Now, before we move into the imaging for the ER, there are basically three big questions we would like to talk about. One is, what is the kind of patient that you're looking at? Is it a low, intermediate, or high risk? So that has to be defined before we choose a technique. The second thing is obviously the diagnostic goal. Do you want to have an anatomical assessment? And our previous speaker alluded to that very well. Or is it a functional imaging that you want? When you're looking at an early disease, you would prefer an anatomical solution like a coronary CT. And if the person already has disease, post-CABG, post-stent, coming with a chest pain, then maybe you would like to see whether there's ongoing ischemia or not. The third big question is, what are the endpoints that we're looking at? Is it length of stay that you're looking at? You want to see downstream testing? What about the cost effectiveness of the technique that you're choosing? So these are the three big questions I believe that we should answer as clinicians before we sort of choose a particular technique. And this will also be governed by your institution, your institutional practices, strength of the institution, so on and so forth. Now, in this very busy slide, there are basically three things I want you to look at. And in the suspected ACS patient, you really want to get the STEMI bucket out of the way. ST elevation, chest pain, risk factors. This person is not going to be waiting for any imaging. It's just that ECG you look at, you're going to document the TROP-T, don't wait for it, and he straight goes in for the cath lab and for a PCI. It is the other two groups where you have either a ST depression or a non-specific STT change or a perfectly normal ECG in a low to intermediate risk. And the next bundle of investigation is going to be the troponin. So the troponin I or the T. Most of us don't do CPK-MB anymore. And depending on that result, the next phase would be the imaging solutions. Now, the imaging solutions will also be governed by the current state of the patient. So, patient low to intermediate risk, troponin elevated, no ongoing pain, you would choose one of the resting techniques of function. So, are you going to do a rest CMR with perfusion or a rest maybe with the nitroglycerin, for example, or you're going to do a CT angio. And it would then, if the patient does not have an ongoing pain, stable troponin T less than the 99% or there's no rise, then a stress test is in order, either a dobutamine, stress MR with adenosine, or a stress maybe with adenosine. We generally don't make these patients to walk in that acute setting. And depending on that result, they would either be sent home or they would be admitted in a chest pain triage unit. Now, as you look at the timelines for ischemia, you will see that the earliest that you're going to be watching is the plaque rupture, which is very well seen on CT. And again, thank you for those beautiful slides. That would be the earliest thing, high-risk plaque, ulcerated plaque that you see. And soon after, you would use any of the rest techniques to look at perfusion, either a contrast myocardial echo or a rest maybe with nitroglycerin or just a rest perfusion MRI would start showing you that decreased perfusion in the involved segments. And as you go along after about an hour, you will start seeing all the echo parameters of diastology. So you the increased E wave, the E prime by E, regional wall motion, elevated diastolic filling patterns, the GLS being altered, and then slowly at about the 6th hour on the MRI, you would see the myocardial edema on the T2 weighted imaging, or if you have a T1 map, you would see those images coming up. And then later, as you reach the 12-hour mark, patients who had a major infarct, you would start seeing the microvascular obstruction and also the hematoma, if at all there is. So based on this ischemia sort of flow, the kind of techniques that you would use would also differ. Now, MRI is well suited in this regard as a complete solution, although I must confess that there are very few centers in this country that would offer an MRI at this particular stage of a patient. So right from T1 mapping, which would show very early sort of edema, the T2 weighted again showing you focal edema, a regional wall motion data set which is very comprehensive, a small focal gadolinium there, showing you that there's a focal infarct, and then the ECV again showing a slightly elevated area. All this can be completed in a single scan, and MR is a very comprehensive solution for this. Now, irrespective of what you choose, very busy slide and it's got all the modalities on it, rest be assured that there are cons also for each. So there's no technique that is perfect, and I must again reiterate the fact that we live in a situation wherein the institution strengths, the operator strength are very, very important. So everything has a con here, irrespective of what you choose. And the guidelines, both the European and across the Atlantic, the American College also has reinforced all these techniques with a certain endorsement in certain situations. So low risk patient, you would like to, patient on bedside, can't be moved, echo is a great technique. Low to intermediate risk, CT is a great tool. We've seen that with some of the CT data, so on and so forth. So when we come to the trials, and I'll just show you some of them. The first one is the echocardiography trial, and this is something that is pan-India. We use it all the time in our ERs. So the ESSENCE trial really looked at two groups of patients who had a kind of chest pain syndrome. So stress echo versus stress ECG. And over the next 2 months, they found that the echo group had a cost saving and a better admission to chest pain units compared to just having a stress ECG on board. And you get all the diastolic patterns, the regional wall, so on and so forth. So it seems to be a more cost-effective solution. Moving on to the myocardial perfusion imaging, the ERASE trial was a large trial with about 2,500 patients, equally divided between those who would have a myocardial perfusion scan. Remember, this was a rest scan with nitroglycerin and standard of care. And what we did see was the hospital admission rate was lower in the MIBI group. The chest pain telemetry units were used more, and you were back home earlier if you went through a MIBI sort of triage compared to the ordinary strength of care. So this really put rest myocardial perfusion imaging as a very, very important tool in the hands of the ER physicians, that if you could use it, then you could have a much more cost-effective sort of way of treating these patients. LIM again looked at a fairly large cohort of patients, specifically looking at the 1-year MACE. And what they did see was that in the MIBI group, they had a significantly lower hospital rate. The rate of invasive catheter angio was also lower. But what was more interesting is that when you had a positive scan, the rate of negative angios, we know that they are almost 40% in some trials, were very, very few compared to standard of care. So a much more cost-effective and efficient use of technique. Moving on to MR, and this is Miller's group, which looked at a lot of single-center studies and put them together, looking at the primary outcome of revasc hospital admission and recurrent cardiac testing versus what happens if you have a normal MR perfusion, you send this patient home. And they answered this by saying that MR was not only safe and efficient, but also it could be said that when you had a negative MR, the chance of missing out or having an issue is very, very low. So that made it a very good technique. It's very important at this point to also talk about the angiogram negative cases with chest pain, younger patients, troponin T positive who come in. And MR is a very good solution to look at those patients. You know that many of them are viral myocarditis. We've had that whole thing during the COVID 1 and 2 phase. And MR is very good to select out these patients, look at the edema, look at the pericardium, and make sure these patients don't go to the cath lab and get heparin and bleed. So the MyoRacer trial saw that the MR is a very, very good tool in these kind of coronary angiogram negative patients. So all in all, MR is a great tool. And the only thing with MR is that although it gives a much better solution, wholesome solution, it's more likely for the higher likelihood ACS patients where you already have disease, post-CABG, post-MI, post-PCI, and then you want to look for ischemia, because at the lower levels, MR is a little more expensive and difficult to do compared to the other techniques. And our favorite, of course, is the CT entered, the CT STAT trial, and one of our close friends, Dr. Kavita, was one of the major authors of this, and they looked at about 6,000 odd patients between the CT group and the standard of care, and of course, the myocardial perfusion was interposed in those who had an intermediate CT. They looked at the time to diagnosis, the cost, and also the MACE. And they really found that in the emergency department, low to intermediate dose CT is an excellent tool. And again, you've seen how we are talking about stenosis, we're talking about plaque, we're talking about high risk. we're talking, all those things can sort of come in, and the CT becomes a very, very good tool to look at these patients in the ER. The ROMI-CAT trial, again by Udo Hoffmann, large number of patients, 500 in each group, again looked at the length of stay, looked at the time to diagnosis, and what we really found was that the patients on the CT group had a shorter stay, they could get back home early, and the downstream testing was also less, showing you that it was a very, very good tool in the emergency department. And the rates of myocardial infarction also, if you use CT as a interposed tool, both in the PROMISE, CORD-HEART, and the CAP trial was lower. However, the mortality did not differ if you use CT or not. And this really put CT as a very, very important tool in the ER for acute chest pain patients. Moving on, the PROMISE trial by Dr. Pam Douglas looked at both the strategies, CT and myocardial perfusion, and when it was done very well, really no difference between the MACE, no difference between invasive catheter. So I think when it is done very well in the right place, right institution, both are, I believe, equal techniques. So in the emergency room, it is very important to do a good history physical exam, do the troponins, and then decide what technique you're going to use depending on where that patient sits in. 2015 guidelines, we've seen the ECG as a very important tool. When we use the heart pathway, which is basically a good history, using the troponins, using the risk factor, using the age, when you use the heart pathway, you can see the early discharge patients are more, hospitalizations are less, stress testing and downstream testing is much less, and the median visit is much less. Moving on to 21 AHA guidelines, the chest pain acronym had a lot of good components in it, including the troponins, the kind of testing, and a structured pathway to be used by institutions, operator-specific, institution-specific to reach your outcomes. So ECG for all, no doubt about it. And once the ECG is done, you move out the STEMI patients out, get a chest radiograph where the ECG is non-diagnostic, you're thinking of pulmonary pathology, use the MRI for myopericarditis. In the low to intermediate, CT is a great tool for no prior disease. For prior disease, you want to use a myocardial perfusion scan or a dobutamine. The future, as again said by the panel, is hybrid imaging, CT perfusion. We're doing CT FFR now in this country. We have started doing, we have some tools now. PET CT, again, already there, and SPECT CT also there. So anatomy versus function, the battle goes on, but I think a collective wisdom to use a combination of both will really help our patients get back home earlier and get the test that they really require. Thank you.